everyone, and as usual, welcome or welcome back. In today's video, we're going to be talking about anesthetic ventilation. As usual, I'm going to be going over some in-depth details about the physiology of ventilation, but if you're just here to figure out how to connect your anesthetic ventilator, just skip ahead here. For the rest of us who are in it for all of the dirty details, let's go ahead and dive on in. Anesthetic ventilators are utilized for patients that are requiring intermittent positive pressure ventilation, which you'll see abbreviated to IPPV. Positive pressure ventilation is the term utilized to describe the type of ventilation that a patient is receiving from an outside source, so a non-patient delivered breath, albeit whatever that source is, whether it's you squeezing the reservoir bag, whether it's the anesthetic ventilator, or even the critical care ventilator. The reason we emphasize the term positive pressure is to highlight the difference in how this breath is delivered versus how a patient takes a spontaneous patient-derived breath. Patient-derived breaths, which again I'm calling spontaneous breaths, are started with a subatmospheric pressure that is created in the chest by the expansion of the diaphragm and the intercostal muscles. By contrast, a positive pressure breath given from an outside source is using positive pressure from outside the body to force air into the lungs. It's important to differentiate the positive pressure used in a mechanical breath versus the subatmospheric pressure used in a natural patient-derived breath because, like everything in veterinary medicine, ventilation can have some negative consequences. Anesthetic ventilators are usually used for just that, delivering intermittent positive pressure ventilation for patients that are undergoing anesthesia. But not every patient that is anesthetized is going to require mechanical ventilation. Like I said, ventilation is not benign, so let's review some of the circumstances in which we either should consider ventilating our patient or just straight up should ventilate our patients. Patients undergoing thoracic surgery require positive pressure ventilation. As I stated earlier, a natural patient-derived breath is started with a subatmospheric pressure in the thoracic cavity, but something that's causing any kind of disruption to the thoracic cavity, be it an incision or trauma to the thoracic cavity, can allow the area around the lungs to equalize with normal atmospheric pressure, thus inhibiting the patient from being able to use the subatmospheric pressure to pull air into their lungs. So in particular, patients that are undergoing thoracic surgery who have their chests open are not going to be able to draw air into their lungs, and they're going to require positive pressure ventilation. Patients with severe pulmonary disease may also benefit from positive pressure ventilation. So patients that are maybe able to breathe on their own but not able to adequately ventilate themselves may require that extra positive pressure to adequately force air into their alveoli. Obviously, we would usually try to avoid anesthesia in patients that are not able to well ventilate themselves, but there are circumstances in which you may not be able to avoid anesthetizing your patient. An example of this is a patient who has sustained some kind of trauma. They may have pulmonary contusions that are preventing them from well ventilating their own lungs. Therefore, they may benefit from some positive pressure ventilation for a life-saving emergency surgery. Another example is an asthmatic cat that may require some kind of life-saving interventional surgery. Something else that can require anesthetic ventilation is control of hypercapnia or hypoventilation during surgery. So hypercapnia is an increased amount of CO2 in the blood, and this is caused usually secondary to hypoventilation, so the patient not ventilating themselves enough. Sometimes that can be caused by too deep of an anesthetic depth and can be remedied by simply reducing your anesthetics. However, for patients that are hypoventilating but do not have the ability to have their anesthetic depth decreased, so they're in a good plane or maybe even too light of a plane for their anesthesia, so we cannot go down on their anesthetic depth, but they're sensitive to these cardiovascular, cardiorespiratory depressants of the anesthetics. Therefore, we're going to go ahead and take over their control of ventilation by putting them on the anesthetic ventilator. An uncommon reason for anesthetic ventilation in veterinary medicine is the use of neuromuscular blockers. Neuromuscular blockers act to paralyze the patient, and that's why it's uncommon in veterinary medicine, because we're not often paralyzing our patients. However, there are some surgeries that either benefit from or require the use of these neuromuscular blockers. An example that I can think of is cataract surgery, where the ophthalmologist does require that patient to be paralyzed, and then even in some laparoscopic surgeries, if the patient has too much abdominal tension or for other reasons, they may benefit from paralyzing the patient. Also, paralytics help you to decrease your other anesthetic agents and therefore help to stabilize your patient. So if a patient is paralyzed, they have lost use of their intercostal muscles in their diaphragm, therefore they require positive pressure ventilation. Other patients who may benefit from positive pressure ventilation but maybe don't require it are obese patients, pregnant patients, and again, patients undergoing laparoscopic procedures. Obese and pregnant patients have increased pressure in their diaphragm, therefore they can have decreased ability to ventilate on their own, particularly severely obese patients that are undergoing abdominal surgery. Pregnant patients do have this increased pressure in the diaphragm and therefore can be prone to hypoventilation. However, we're usually running their anesthesia a little lighter to minimize risk to the neonates, and therefore they don't always tolerate being ventilated, because patients usually do need to be at a specific anesthetic depth to tolerate the feeling of positive pressure ventilation. And laparoscopic surgeries can benefit from the positive pressure ventilation for the same reason that air in the abdominal cavity can cause increased pressure on the diaphragm. There are consequences to positive pressure ventilation. The primary one that comes to mind is decreased cardiac output. Remember, cardiac input equals cardiac output. Mechanical ventilation increases intrathoracic pressures, which thus put pressure on the greater vessels in the chest cavity and can reduce venous return to the heart, thus reducing cardiac output. So a consequence of mechanical anesthetic ventilation is hypotension. Usually healthy patients don't struggle with this as much, but patients that have some kind of severe hemodynamic compromise, such as septic SIRS patients or patients that are severely hypovolemic dehydrated, are going to be more prone to this decreased cardiac output during ventilation. So it may be a benefit to reduce the volume or the pressures that we're ventilating them to help decrease this side effect. The two primary causes of ventilator-induced lung injury are barotrauma and volutrauma. So barotrauma is trauma from increased pressures in the lungs leading to air outside of the alveoli, and volutrauma is due to increased volume in the lungs and is causing over-distension of the alveoli. We can talk about the mechanisms for ventilator-induced lung injury for an hour just on their own. So I'm going to leave it at saying that studies support that volutrauma is the leading cause of ventilator-induced lung injury. Therefore, it is extremely important to be monitoring the volume that you're giving your patient in addition to the pressures that you are ventilating your patient with. So now let's talk about the anesthetic ventilator itself. There are a few different types of anesthetic ventilators, although in veterinary medicine, the most common type of anesthetic ventilator is a double circuit ventilator, which uses a driving gas force and a patient gas force. Now again, there are multiple kinds of ventilators, but as this is the most commonly used one in veterinary medicine, it's going to be what I'm focusing on for this video. This type of ventilator has a bellows housing, which allows the bellows to rise as the patient is exhaling. The bellows act to replace the reservoir bag on your anesthetic unit. Most of the time, these ventilators come with different sized bellows, usually a pediatric that goes from around 0 to 300 mils of air, and an adult bellows, which goes from around 0 to 1500 mils of air. You can see there's overlap in these. They both start at 0, and you should use the size that's most appropriate for your patient. In general, in veterinary medicine, we can say that patients below 15 kgs can use the pediatric bellows, while patients over 15 kgs can use the adult bellows. But really, we should be looking at what their tidal volume is and what bellows fits them most. So you can't necessarily go just based off of size alone. If you have a patient who is 18 kilograms and is morbidly obese, they may still do fine with the pediatric bellows if we're going off of ideal body weight as opposed to actual body weight. The ventilator connection parts consist primarily of a power plug, a breathing system hose, which is connected to the spot on the ventilator where the reservoir bag would be, an exhaust hose, which is connected to a scavenge system, a driving gas hose, an oxygen supply hose, and an airway pressure sensor T, which is connected prior to the inspiratory limb of the patient circuit. The type of controls that your ventilator has is going to vary depending on the brand of ventilator and how modern the ventilator is. In general, ventilators will come with an ability to adjust the volume, which often comes with a micro and macro adjuster, an ability to set the respiratory rate, and then a maximum working pressure limit. The maximum working pressure limit knob allows you to set the peak pressure that the ventilator will deliver a breath to. Some ventilators also come with inspiratory to expiratory ratio controls. Not all of them do, and many of the standard ones actually don't. If your ventilator does not have an ability to set this, it's likely preset with either a 1:2 or a 1:3 expiratory ratio. We naturally spend more time expiring than we do inspiring, so using an inspiratory-expiratory ratio of 1:2 or 1:3 is usually what is most comfortable for the patient and will allow them to be ventilated with ease. And then some of the new fancy ventilators come with a screen that allows you to see your ventilation metrics and gives you pressures and volumes real time as it's delivering the breaths. But again, most of us don't have the pleasure to be working with a ventilator that's this nice. And then most ventilators also come with an inspiratory hold button. And what this will do is allow you to hold your patient at peak inspiration. And this is used in some procedures that require inspiratory holds, such as giving a breath hold during a CT to prevent lung movement causing artifact in your images, and a breath hold in a thoracotomy to do a bubble check. All right, so we've reviewed the basics of a ventilator and situations in which you should ventilate your patient. Let's talk about actually setting up the ventilator. In this video, I'm going to be using a universal F circuit. It's what my clinic has, and it's what a lot of veterinary clinics utilize. Before you begin, always make sure to check your anesthetic machine, all your hoses and attachments. Most clinics do not use their ventilator for every patient, so oftentimes things will be disconnected. Ensure your ventilator is connected to an oxygen source. Not all anesthetic machines have the split valve that allow you to connect the ventilator to it. For example, at my work, we have specific machines that are set up to be used with ventilators, so make sure that your machine has the ability to connect to a fresh oxygen supply. Next, you need to be attaching your breathing hose to the space where your reservoir bag usually is. You do need to close your pop-off valve to use the ventilator. So when I connect the breathing system hose, I close the pop-off valve. And then do not forget, when you are done using your ventilator, to open your pop-off valve. If your anesthetic machine has a safety valve, such as the Superior valve, you do need to make sure that you have the valve blocker appropriately attached. Otherwise, you will not be able to fully ventilate your patient. Your ventilator will think there's a leak in your system. Next, ensure your exhaust hose is connected to the scavenging unit. And then next, connect your pressure sensor T before the inspiratory limb of your patient breathing circuit. If you forget this step, your ventilator will be alarming the second you turn it on. Next, attach your chosen bellow size. The pediatric bellows fit into the center ring, and the adult bellows fit into the outer ring. And make sure for the adult bellows that you're only using the end of the accordion. If you have attached too many steps up in the accordion, then this will not allow the bellows to fully inflate. You also need to make sure that you're taking any creases out of your accordion so that it can inflate appropriately. And then place your bellow housing secured back on your unit so that you can see the volume indicators on the front. Next, perform your pressure check using a reservoir bag. I like to use a reservoir bag that is closest to my patient's tidal volume. You can set this, start your ventilator, and make sure that your bellows are inflating back to the top with every ventilator breath, because if they do not return all the way back to the top, this is an indication that you will have a leak. Next, set your rate and volume knobs. I usually start with my respirations at 10, and I may adjust this based on the patient's needs. And I like to start with my volume knobs all the way down. Some people like to preset their ventilator using a reservoir bag. The only thing I don't like about this method is it makes me feel a little paranoid that the reservoir bag I'm using is bigger than my patient's tidal volume, and so I may be oversetting the volume as opposed to appropriately setting it. So I prefer to just have it all the way down, and then I adjust it for the patient as I'm putting them on the ventilator. This may be less important with large breed dogs or patients where the tidal volume is estimated to be really similar to the reservoir bag that you're using. The alarm on the ventilator will initially start sounding if your pressures are below 5 centimeters of water, but as you increase your volume and thus your pressures, the sound of the alarm should go away. Most anesthetists prefer to ventilate their patients somewhere around the 15 centimeters of water pressure. I usually say somewhere between 10 and 15, with a preference for staying on the lower end of the pressure for patients that are hypotensive or severely hypovolemic, in which I'm worried about, again, that decreased venous return. Now, I prefer to set up my ventilator watching my pressure. So again, I will usually increase the volume until my patient is at the appropriate pressure, usually between 10 and 15. But you do also need to be keeping an eye on what volume you're giving them. So I will tend to set my patient to the pressure that I am aiming for and evaluate what volume the bellows are delivering to the patient, and calculating and making sure that that volume is within my expected tidal range. Now, the problem with this setup is that if there is a problem with your pressure sensor, you may see differences in the expected pressure compared to the expected volume for your patient. So an area where I particularly tend to see this at my clinic is when I'm performing an MRI, particularly on a small breed animal. So for MRI, our pressure sensor is well outside of the MRI room, pretty far away from the anesthetic machine itself. And so I do tend to see kind of big discrepancies in what pressure the machine is telling me I'm at versus what volume I actually see my bellows going to. So if I'm seeing my bellows are dropping down to volumes 15, 20 mils per kg, I may choose to ventilate my patient based on the volume as opposed to the pressure, so that again, I'm making sure I'm reducing their risk for trauma or ventilator-induced lung injury. It's also important to remember that if you adjust the volume or the rate on your machine, you are going to be adjusting the peak inspiratory pressure. So if you're increasing your respiratory rate, you also need to increase your volume, otherwise your peak inspiratory pressure will fall. If you are decreasing your respiratory rate, you also need to decrease your volume, otherwise your peak inspiratory pressure will rise. Now let's talk about why your ventilator may be alarming. So most of the ventilators, again, these old ventilators don't have a digital display that just tells you what alarm is going off. They have two sounds that they make, and it's up to you to figure out why it's happening. So as I stated earlier, you have a low pressure alarm. So the ventilator will sound if your patient is not reaching 5 centimeters of water for their peak inspiratory pressure. And to remedy this, you just need to go up on your volume. Your ventilator will alarm if your patient is disconnected, so make sure all of your tubing is still connected together. Your ventilator will alarm if your oxygen source is running low. So if you are not using drop-down oxygen that has an endless supply, if you're on some kind of tank system, make sure you check your tank and see that there's oxygen available for your ventilator. Sometimes ventilator will alarm when the patients are breathing on their own. Oftentimes this is the result of your peak inspiratory pressure getting too high because the patient is inspiring at the same time the ventilator is delivering a breath. Therefore, their pressures get really high. So if this is happening, you need to try to catch your patient on the ventilator by either increasing their anesthetic depth if they're too light, or increasing your respiratory rate so that you can try to ventilate the patient enough that they're not driving their own ventilations. Your ventilator will alarm if you have reached your maximum working pressure limit. So again, that pressure limit that you have set the ventilator to not exceed. When a ventilator has hit its maximum working pressure limit, it'll flash yellow and it'll stop delivering the breath. So to remedy this, you need to either decrease your volume, or as I just stated, you may need to try to catch your patient's respiratory cycle by increasing the respiratory depth or increasing the respiratory rate of the ventilator. If the excessive pressure is not immediately resolved, your ventilator will begin to continuously alarm. In the event that this happens, immediately disconnect your patient from the ventilator, switch to a reservoir bag, and then problem shoot your ventilator after your patient is secured onto an appropriately working anesthetic ventilator with the pop-off valve open. And then one of my favorite alarms, the most common one that's often the most underlooked issue, is the airway pressure sensor T is not connected to the inspiratory limb of your patient. All right, so now I'd like to take a second to talk about capnography because it is the most useful tool when deciding if you are appropriately ventilating your patient. I know if you've watched any of my other videos, you've heard me talk about capnography and my opinion that it's one of, if not the most useful tool you have available when monitoring anesthesia. Capnography is going to allow you to know if you are hypo or hyperventilating your patient, and watching the waveform is also going to tell you a lot about what your patient's endotracheal tube and lungs are doing. So when you're ventilating your patient, you are aiming for a normal end tidal CO2, somewhere around 35 to 45. Remember, cats can be naturally a little bit lower than that. If your end tidal is low, you are hyperventilating your patient, you should decrease your respiratory rate and volume. If your end tidal is high, you are hypoventilating your patient and you should increase your respiratory rate and volume. All right, so that's the basics of anesthetic ventilation and how to set up a standard anesthetic ventilator. If you have any questions, please leave them in the comments below. And I'm probably gonna follow this video up with a video about how to interpret the capnograph and different capnograph waveforms, so stay tuned for that. Meow. Wally Wally. This increased pressure on their diaphragm just from, however,